Good morning, everybody. Welcome to another meeting and program of the Coronado Roundtable. We have coffee this morning, so please help yourselves. I'm Christian Escoven, the current president of the Roundtable, and welcome on this gloomy September morning. We usually have Santa Ana's, but I guess we're in one of these cycles where we have the June weather. But I'll start the meeting as soon as we can get ready for a Pledge of Allegiance. So please stand. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible. As you may know, our programs are recorded for live Zoom recording. So we'd like to thank the Coronado Public Library for continuing to provide this service to us and to the community. Yes. For those viewing at home, please mute your computer or device and please turn off your camera. You may use the chat box function for a question and answer portion of the program that will follow. Please let us know if you can't hear at the back of the room. And we'd like to thank this morning Selena Valladolid, who is handling all of the AV services. And the Coronado Roundtable, as usual, would like to thank the Coronado Library Board of Trustees for continuing to consider us a sponsored organization. In that manner, we can continue to hold the programs here at the Coronado Library. Our coffee is provided by Alex of the Amalo Brew, the coffee cart service in front of the library. And we do ask for a $3 donation for that service. We are holding next month another program I'd like to draw your attention to, and that will be featuring Dr. Kai Wynn from the Stein Institute on Aging on October 25th, and the subject will be on graceful aging. This morning, we were supposed to have Mayor Bailey, but he had to cancel. But we are very pleased to have Dr. Stephen Phillips, which we did feature once before. He will be speaking on the information needs for national medical preparedness and response. And here to introduce Dr. Phillips is the Coronado Roundtable's own board member, Dr. Suzanne Popp. Suzanne, would you like to introduce?
Thank you, Christian. Good morning, everyone. It is my pleasure to introduce Dr. Phillips. Dr. Phillips is a retired heart surgeon. He has previously spoke here out to the roundtable on heart transplants and other fun things he did. From approximately 2000 to 2016, Dr. Phillips served in the government as a senior manager at the National Institute of Health, NIH, as the director of the Division of Specialized Information Services, SIS, of the National Library of Medicine. SIS provided open source authoritative information on areas of disaster preparedness and response, toxicology, hazardous substances, environmental health, climate change, disease surveillance, and related subjects. In 2006, Dr. Phillips was tasked as the multi-agency COO to help create a hospital surge model for the US, a congressionally funded program, which is the subject of today's talk. Dr. Phillips is married to Susan Phillips. She's here today, and they live in California, Coronado, California. Thank you. All right, please come up. Thank you.
Well, thank you. Thank you very much. And good morning to everybody. It's a different hat that I'm wearing today. I spent the last 15 plus years of my life related to disaster preparedness and response. And to start off, since I grew up in Brooklyn and was a Brooklyn Dodger fan and still have PTSD when they moved to LA, I'm happy to show a very brief video of the disaster that befell the Dodgers the other day. Now, if I can get this to work. Everybody has seen this and know about it, so let's get on with the. Okay, great. Thank you. Well, as I mentioned, strange things happen to all of us. We move from different positions based on what someone needs, not perhaps what their abilities are. When they asked me to get involved in the disaster preparedness and response, I said, why me? He says, well, you were a heart surgeon, you know all about disasters. I said, thank you very much. But I think it was my military background, and I had been involved in response and recovery for many years. I did spend about 15 years, and from this, you could get the idea of this multi-agency interaction that we had and the ease of getting from one agency to another. It was a disaster on its own. Department of Defense, Health and Human Services, the FBI, EPA, insurance companies, et cetera, and we'll talk more about that. I just wanted to quickly go through what is a disaster, because we have to categorize these things in order to be able to respond and prepare. Acts of nature. I mean, we have a giant hurricane going on right now. The tsunamis, the tornadoes. I lived in Iowa for a number of years, and we had our share of tornadoes. Natural phenomenon are the most common, but there have been accidents over the years which have been devastating. An example, in 1984, the Union Carbide Company accidentally released 40 tons of hydrogen cyanide gas into the atmosphere. Roughly 20,000 people were killed. We don't know the exact number, but many more injured. In Spain in 1982, rapeseed oil, which is commonly used for cooking, was contaminated with aniline toxin. And a lot of people died from that. Pure accident. The Soviets released, and I'll tell you a very quick story, anthrax into their city atmosphere accidentally. The way they produce anthrax is you cook it up in a big vat, and then you spread it out on sheets. It's massive, massive sheets. And then you dry it by blowing a fan over it. Well, the night manager apparently of this anthrax facility was drunk, and he forgot to put up the screens. So when they turned on the fans, all the anthrax blew out into the neighborhood. A lot of people died. Now, something that some of you may be aware of, but I wasn't aware of until I learned about it. 51 nuclear weapons are missing, have been lost worldwide. US has lost 6. We don't know the exact number, but there's a hydrogen bomb in the bottom of Savannah Bay somewhere. It's been there for about 30 years, and so that. And of course, Chernobyl. Chernobyl was a total disaster. this is a little map of the area that the immediate nuclear reaction hit, covered most of Europe, and the radiation cloud is still traveling around the world. It's slowly dissipating, but it was estimated that between 200,000 or 300,000 people will probably develop some form of cancer because of that. And in the United States, we have 41 nuclear power plants. And you never really read about it unless it's a major disaster, but 41 or 43 had leaks over the years. Accidents waiting to happen. And of course, terrorism, we're all familiar with that. The sarin gas attack in Tokyo, remember that? A number of people died. A number of people were sickened. And the one thing that the perpetrators did not know is when the train came through, it dissipated all the gas. So they would have been better off if they wanted to really do damage to do it in the shopping mall or somewhere like that. First responders and receivers also got sick because they just didn't even know enough to take the clothes off the people who were contaminated, and therefore they got contaminated. World Trade Center we know about, the anthrax letters we know about, Oklahoma City, the train explosions in Spain and India and the UK. Quick story about the UK. The UK knew that there was going to be a bomb on a train because they were told by the Israelis to prepare. They canceled the leave of all of the first responders and receivers. And when it happened, they were at least able to respond very quickly and save lots of lives because they expected it, but they didn't know where or when. I just might mention very quickly, when I was working in the government, I went to a monthly briefing from the CIA about how we were going to be attacked. This was 11, but they never determined how the attack was, and then 9/11 happened. So we know things are going to happen, but we don't know when and where. And I want to talk a little bit about that later on. Cyber terrorism, we hear about that every day. And of course, one of the reasons the program I will talk about happened is because in the early 2000s, we were very afraid of a biological attack. The bad guys infecting 50 or 100 volunteers with something like smallpox, which has a 3 or 4 day incubation period, putting them on an airplane, they could be anywhere in the world, healthy seeming at the time, and landing in the US. I just want to describe the difference between a bioweapon and a pandemic, because we faced a pandemic just a few years ago. We may be facing another one sometime in the future. We don't know. Now, a bioweapon, an epidemic or a pandemic travels in a wave. It starts in one place and moves across the landmass and ends up where it ends up. A bioweapon is multicentric. It'll happen in multiple places at the same time. That's one way of determining what is going on. Of course, they blend into each other when we travel and so forth, but that is the basic standard. Interestingly enough, in 2006, Homeland Security said, we no longer want to deal with disaster preparedness and response, especially in the medical area. So they turned it over to the Department of Health and Human Services. It seemed a little strange at the time, but the Department of Health and Human Services had the ability to do things like that. Why did that happen? Well, if you look at our hospital system, we are not prepared for a surge need. We are not prepared in any fashion. There are studies from multiple studies, the Institute of Medicine, American Hospital Association, lay press, et cetera, had determined that in general, we have no ER capacity for a surge. We don't have enough hospital ICU beds, And we have few regular beds if there's a major problem. And so we're not prepared. Examples, 9/11. Bellevue Hospital, they lost track of their patients, ran out of supplies, and struggled with staffing. New York Hospital downtown, again, lost electricity, steam, phone and computer services, and didn't have water. St. Vincent's Hospital, which is a major hospital in New York, shared water lines and telecommunication with the World Trade Center. So they were disrupted. The issue is that the US health system, as good as it may be, has no central control and command, unlike other countries which have central control and command communications. I spent some time working with the Israelis, and they have a medical command and control center that's about 10 stories underground. And they know where every doctor, every nurse, every technician, every bottle of blood is, et cetera, 24/7, and where they move to. So when they have to obviously activate, they can do it much more quickly than we can. Again, if you remember, our doc, your doc, my doc, that works at one hospital cannot go to another hospital unless they're credentialed. And that goes on with patient information. And some of you may have experienced that. Your records from one place are hard to obtain and go to another place, and so on and so forth. And it's like that, excuse me, with supplies, communication, billing, especially billing. So what we did was, since everything went to Health and Human Services, they established an assistant secretary for preparedness and response. Everything has an acronym, ASPR. And they asked ASPR to create a playbook, just like the military has playbooks to respond to any sort of major problem. To develop a reproducible hospital model, to create standard tools for responders and receivers, and also monitor for potential disasters. And I'll talk a little bit about how we were doing that at the end. The strategy to respond is that every event is different, whether it's accident, terrorism, or natural occurrence. So what we had planned to do, and we would plan to identify a city and then identify a hospital in that city that could be the receiving hospital for those patients, depending on what the disaster was. You would also cross-credential the staff so that they can immediately go to work at a place where they were not credentialed, but certified by the state and the US government as technicians or physicians, nurses, or whatever. And then have the ability to transfer patients from that receiving hospital to other hospitals so they can open up beds. The big issue was insurance companies, are they going to pay? You know, they will find any reason not to pay. If you had your gallbladder out in one hospital and that bed was suddenly needed because there was an emergency and you got transferred to another hospital, which they perhaps were not participating with. So that was something that we dealt with, and we had all of these things in place. I want to talk to you about how we established this hospital partnership. We were in Bethesda, Maryland, and within a mile of each other, there are 3 hospitals: the National Naval Medical Center, the NIH Clinical Center, and the Johns Hopkins Suburban Hospital Center. And the idea was to strengthen communications between the hospitals and make them interoperable so that they could communicate during a disaster. improve patient managing and tracking so that patients didn't get lost during transfer, and maintain information about the patients, information about the staff, and so forth. And this is just a picture of the three hospitals that are about a mile apart, and we use that to develop the model. And what happened was they came to me and said, okay, you're running this division that deals in toxicology, hazardous chemicals, communications, environmental health, climate change, et cetera, et cetera, et cetera. And I had a staff of about 70 people who all had advanced degrees, were subject matter experts in all these areas. They said, we want you to kind of run this. I said, oh, okay, I'll do my best. And we started out with 11 R&D projects related to creating a playbook for a hospital partnership. Strengthen communications, maintain information access, support responder training and education. And these research initiatives were communication backup, and I don't want to get too technical, but you could use laser on the rooftops to communicate. Dark fiber, which is cable. We had dark fiber, and you can activate that. The cable companies were very happy to help out. The ham radio operators were backups. They had an organization, and we could send emails through the ham radios or direct talk, and wireless bridges. Patient management, I'll talk about a digital pen, patient data exchange, and patient RFID tracking, which was easy. People get lost, lost person finder, and I'm going to show a little video about that. And when a patient arrives at the hospital unconscious or in distress, you know perhaps their name, or you identify them in some way, and there is a central database of medications that we all take. It's a little hard to access, but the big pharma companies, the CVS's and the Walgreens and so forth, have opened up their files so that they can identify what medications I might be on. Am I on a blood thinner? Am I on a heart medication, et cetera? And so when they arrive, you can identify that. And before we show the video, I just want to say that we had identified 3 other cities because our model was tried and true and detailed. I was out here in San Diego in 2012, and we were working on it with the folks here. And the other 2 cities that we were going to start with were Portsmouth and Sarasota. And I just might mention that we know every state have a VA hospital. The VA hospital have many beds, they're underutilized, they're well-staffed, and that would generally be the target hospital to receive the patients, and also would be the target hospital to transfer the physician, the nurses, the subject matter experts related to what the disaster was into the VA without having worrying about credentialing and so forth. So could you help me with that video? Because I don't want to create another disaster. It's about a 10-minute video, and it describes our model. And this was done by the US Navy. It's a little graphic.
Hey, Tina, Sandra, it's the last day here in New together. I'll stay together everyone. It's cold tomorrow. So we thought we'd show you guys the place we're really gonna be hang out spot. Yeah, I'm gonna miss you. I'm gonna miss you guys. So check it out. Enjoy what we do. All right, here we are at one of our favorite places to come shopping. It's pretty low key. It's really cool. We're right down there. That's where you get those, the other cool place. Like so far. We graduated college. We're totally getting this condo, right, y'all? Hey, we're here right outside of one of our favorite restaurants here in downtown Bethesda. They've got great food, great drinks. We know the owner who loves us.
interrupt our program to bring you this breaking news story. We are getting reports of multiple explosions in downtown Bethesda. We don't have much information at this point whether this was a terrorist act or an accident, but I would say at least an area of 2 city blocks has been destroyed. There are reports of hundreds of casualties, and emergency responders were trying to reach the area. Obviously, there was a lot of debris covering the street. Fire police are having a difficult time reaching the victims. Meanwhile, all access to downtown Bethesda is blocked with no emergency vehicles being allowed in. So if you have family or friends in the area, please stay tuned. And update you. Great job. Just to recap, multiple explosions have been reported.
No community is immune from the shattering effects of disaster. In 2004, leaders of 3 Bethesda, Maryland hospitals with distinctly different missions recognized the risks their community faced if a disaster occurred. They chose to work together in a pioneering partnership to ensure a coordinated and sustained hospital response.
Washington, D.C., of course, is the nation's capital. We learned in a terrible way on September 11, 2001, that we are going to be a target. We are the symbol of America's power.
It was quite clear that we had absolutely no plan for coordination of efforts. And really, it was each hospital on its own.
And Admiral Arthur was quite a guy, quite a thinker, and we were sitting in his office, and he stepped up and walked over to an aerial photograph in his office, and he pointed to this area where you could actually see the National Field Medical Center. You could see NIH in the middle, and then you saw suburban. I've also been thinking about this. He said, we have here a medical megaplex. And by creating a unique partnership between a military facility, a research organization, and the regional trauma center.
I think everyone recognizes that in times of distress and in times of disaster, most of what you plan is not going to go the way you've planned it.
When you're talking about a mass casualty event, it's very rare, in fact, be hard-pressed to identify any institution that by itself can respond adequately.
So in that regard, knowing one another, partnering with people, meeting counterparts, coming together, doing dress rehearsals, doing exercises is a wonderful way of coming together to make sure that we can, in times of emergency and disaster, actually make that happen.
Hoping is not a public policy solution. You have to prepare, you have to do the exercises, and you have to have the resources to do it. That's what the Bethesda Emergency Partnership is all about.
Early in the joint efforts, a collaborative leadership structure was put in place. Representatives from each hospital met every week and developed solid working relationships. Plans were put in place to ensure communication systems interoperability, to share hospital beds in disasters, and to share resources, equipment, and supplies. While planning was critical, testing these joint plans was equally important. Beginning in 2004, the Bethesda hospitals conducted a major disaster response exercise called the Collaborative Multi-Agency Exercise, or CMAX.
We all know that a mass casualty event, the danger is you have pandemonium, you have people going in a million directions, and when the event happens, you don't want that to be the first time that you've gone through this exercise.
This whole partnership is built on the idea that given that we have these wonderful facilities pretty close to each other and have good working relationships, we have a kind of a luxury of thinking through things ahead of time and finding out what we want to do and being prepared and testing out some of these ideas to be sure that if and when a problem arises, that we can work.
We are at National Naval Medical Center, as are most people in the medical profession, in the readiness business. Our job is to be ready at any time to respond to any threat. The CMAX is basically a collaborative effort to bring everybody together and find out through dry runs and rehearsals, where are the kinks in your process when you try to talk to each other. It can be something as simple as not knowing the common radio frequencies to misunderstanding what somebody's trauma capability is.
In 2008, the National Library of Medicine, whose mission is organizing and providing access to health information, joined the Bethesda Hospitals Partnership. The National Library of Medicine, the world's largest medical library, plays a critical role in translating biomedical research into practice.
National Library of Medicine and an emergency partnership. How does that work together? Well, quite simply, they're in the business of information. And once we recognize that and said they would be a natural partner here, this thing is really taken off, because if you think about what the biggest problem is in any crisis, it's communication and moving information.
Yeah, our National Library of Medicine, like most medical libraries, has really focused on communication. And of course, in disasters and emergencies, communication between departments. So we have some techniques that could be added and help the group. We've been doing this for 20 years and are delighted to see all this kind of come to fruition, at least fruition in test setting, with these three wonderful partners out here.
One goal of the Bethesda Hospitals Partnership is to expand the science of emergency management. With congressional funding, the partners launched a research program in 2008 aimed at exploring new ways to sustain disaster communications, manage patient data, and educate hospital personnel. Coordinated by scientists at the National Library of Medicine, 11 projects are underway to evaluate innovative strategies to improve care in a disaster. One project is testing the use of a radio frequency identification device, or RFID, to track patient movement through the hospital. This will provide hospital leaders with real-time information about how many patients they are caring for and where the patients are receiving care. Another project is evaluating a system known as the Lost Person Finder, which is being designed to reunify family members by capturing basic patient information, including photos. When many patients need care, triage permits the hospital to determine priorities. Triage notes taken by a nurse or physician are customarily written on a paper form that can be lost or damaged. The hospital's partnership is testing the use of a digital pen containing a tiny camera that captures the written triage notes. This critical patient data can then be transferred to an electronic database where it can be preserved. It's also immediately available to other clinicians and decision makers in the hospital's emergency command center. The innovative strategies used in this partnership can be used in many other communities in the U.S.
I've been privileged to work with my colleagues to obtain federal funding. Congressional support for this project is very high because Congress recognizes that this is a very important national model on how you respond to mass casualty events.
And so our hope is that this model will serve as a template for other partnerships around the country to capitalize on the strong capacity of each of the hospitals in the neighborhood and create a plan so that people communicate.
Make the effort, get together. If nothing else, just start talking informally and find out that many of you have the same challenges. You will also find out things that you hadn't considered, and they will learn from you. And this is exactly what's happened here. This all started initially with just a few phone calls from a few senior people. It's now blossomed into a collaborative effort that involves a fair amount of resources, technology, and personnel. And we are much, much better prepared today to deal with the mass casualty in this area as a result of our collaborative efforts.
So we need to make sure that we leverage the best of each particular entity as we come together and we build the plan and we do the prep.
We'll stop it here because the rest is just political talk. We had lots of infrastructure support from Congress. Both sides of the aisle were very happy to throw money at us, and I'll talk a little bit more about that. I just have to say that during one of our drills, we would use the medical students to dress up as the wounded. They'd be covered with fake blood and bandages and so forth. And prior to one of the drills, when there was a carload of medical students turning into the National Naval Medical Center from Wisconsin Avenue, where the drill was going to start, and there was a little fender bender. And the kids jumped out of the car to try and help whoever was they were in the fender bender with. And that person had to go to the emergency room because he saw all these people with blood and bandages and so forth coming out. It was really, really funny. So all things like that happen. Anyway, just very quickly, you have a mass casualty event. Patient data is retrieved during the digital pen with the digital pen, transmitted to the receiving area, and the reports are available. And we drilled quite a bit. This is a drill that we carried out with SEAL Team 1 here, where we had the SEAL Team medics during a simulated disaster use the pen. And here you can see one of the medics holding the pen. There's a little camera to take a picture of the victim, the lost person finder, and the data is transmitted. So it's interesting. Now, I talked about our response in the first few minutes of this conversation. But I want to talk about preparation. And preparation is a lot more than just having a first aid kit in the back of your car or a warehouse full of ventilators. And I want to refer you to a very interesting book called Book and Danger. Dagger, I'm sorry. The library rats who helped win World War II. Kind of a strange wording, but the library rats who helped win World War II. Well, information is critical. And there are two types of information. The information that James Bond and the other spies obtain, they steal information from people who don't know the information is being stolen from and so forth. That's not what we were doing. We were looking at open source information, newspapers, communications, and all this was started by this fellow, William Donovan, the founder of OSS, Office of Strategic Services, during World War II. And what he did was gather up from universities and other types of intellectual places, librarians, and had them searching for information about different things related to the war. Well, let me just explain what this map means. The National Library of Medicine was the head of a network of 6,000 libraries, nationally and internationally. And all of these libraries, like this library, are connected in some fashion to the public libraries. So you have a tremendous source of people who are constantly looking for and providing information, librarians. So we went ahead and created something called a disaster information specialist librarian. Now, library science has lots of different subspecialties. There are public librarians, there are school librarians, there are map librarians, and so on and so history librarians, so on and so forth. And so we created and certified a disaster information specialist librarian. And this idea caught on very quickly. Librarians in different communities were already sitting in the emergency operations centers of a lot of cities, and including Washington, D.C. And if someone needed information about something, there you go, you went to that person. They didn't have to search on their own. So that is part of what I want to share with you. Information. Well, if you have data from different places, how do you organize that data so that you can make an appropriate decision about something? Well, we do this normally. The seasonal flu. We have people, mostly librarian types and CDC and so forth, that know that where the seasonal flu starts every year. By the way, get your flu shot. It usually starts somewhere in South America and works its way upstream or whatever to us. And during the transition, we determine the strain. You assess the virulence of those particular strains, and you create a vaccine. So that data is organized by the time of year, the population at risk. No, seniors will be notified to get your flu shot before kids in high school, and so on and so forth. And we also identify high-risk areas, cities versus rural towns and so forth. And it's something that we don't even think about, but that requires people to do this. Now, something that happened and upped my security clearance quite a bit was that we started looking at our web logs, and this is across all the libraries. What are people looking for? In the past, and they still do this, Homeland Security, NSA, whatever, all the three-letter agencies, they're always monitoring what people are doing, listening to their cell phones, so forth. But what are they looking for in the library? Well, it all started back in 2012. It was a Friday night. I got a call from one of my senior staff, and they said they were looking at our web logs, and there were people looking for the management and antidote to sarin gas. I said, what in the world are they doing that for? Is this some sort of high school seminar group or some kids fooling around? I said, where were these people searching from? They said, two sites on the Syrian-Turkish border. And at that time, I called the duty officer at the White House, and they got on it immediately. And they connected with some of the other intelligence folks and said, the Syrians are moving their rockets and they're loading them with sarin gas. And that was before they attacked their own people. Well, we had 10,000 troops plus over in Turkey. The Israelis are in that area and other friends are in that area. So we began notifying them of this activity. They asked me on Saturday morning, can you create a sort of a briefing on what sarin does, how it works, how to identify it, how do you protect yourself from it, how do you treat it? We convened the subject matter experts, and by Monday morning, we had a 6-page pamphlet on all that. I said, no, I want a card, an index card, a plastic card, where on the front it says how you identify it, how the respondent protects themselves when they're treating a patient, and on the backside, what the antidote is, which is atropine injection. And we did that by midweek, and the Israelis distributed about 100,000 syrettes of atropine as an antidote. And one of the toxicologists said, oh, that's the wrong dose. So we had to recontact them, and they judged that. But when we were monitoring our web logs, and you can see how it just over a few months, it increased to it peaked until they released that. Now, another event that happened, someone was accessing our site looking for an accelerant, something to burn something very quickly. And they kept accessing it from the same site, and it set up some red flags. And the FBI went ahead and they arrested an illegal Iranian in Arizona who was looking to do a dirty deed. And there were lots of events like that. The other thing about librarians and data management is if you combine unrelated databases, you might come up with something interesting. And this is something else that we did. This happens to be the immigration at the airport. We took the data, the death data of people and pets, and we correlated that with the issuing of passports and turned it over to Customs and Immigration. And someone comes through, but you're dead. You're a poochie. You don't belong here. So are we ready? I just have to interject that all of this started in 2001 after 9/11, as I mentioned earlier. The Bush administration gave us seed money of $12 million to start this, to prepare for a pandemic. Not anything else, $12 million to prepare for a pandemic. How they knew or what motivated them to choose pandemic is beyond me. So what I talked about, and there are many moving parts and a lot of other issues that I don't have time to discuss, but we could talk about some things during the Q&A. Are we ready? Well, in 2009, we published a paper in the Navy Proceedings, authored by myself and Admiral George Worthington. George, I don't know, some of you may know George, had retired as the commander of Naval Special Warfare, SEAL, was a friend. And I asked him to come to DC and help us with this whole project based on his connections and experience. And in the story, if you're interested, you can go online and read the report in the proceedings of the Naval Academy. Are we ready? Well, we were almost ready. We tried to develop the playbook. We didn't quite get there. And if anybody wants to know why, I'll discuss it in the Q&A. And that's about it. Thank you.
Thank you, Dr. Phillips. We can, I think we can move directly into the Q&A portion. You're welcome to get up and get a cup of coffee if you're so inclined, or use the restroom. Otherwise, Mike, are you here? Okay. As soon as Mike comes back, we'll start the Q&A. So we have a couple of minutes.
I'll start now. I'll just talk loudly.
Okay.
Thank you, Doctor, for a wonderful presentation. And my question is, could you summarize your impression of how the San Diego area is ready to confront the mass casualty? Because we have some of the same capabilities that are nexused in the Washington, D.C. area.
No, great question. And San Diego was targeted as the second city that we were going to apply that model to. And if you go down Genesee Avenue over in La Jolla, you have a megaplex. You have UCSD, Scripps, Sharp, all together. But again, as you know, there is some, but very little communication because they're competing. My impression, having spent 60 years in medicine, is we are at the point in our healthcare system, which is decentralized. It's universal healthcare for profit. Our facilities are excellent. Our physicians are terrific. Our nursing staff, our technicians, they're all top notch. They're the best in the world, but getting access is very difficult because it's a bottom line issue. We can do this. And I think we can do this very quickly. And unfortunately, it probably will happen if there is a local disaster. But we should be able to do this ahead of time. We don't have to do this on a routine basis. All we have to do is have the authorities flip a switch and say, okay, now you hospitals are gonna, you're the receiving hospital, you're gonna transfer patients out, you're gonna get the patients, we're gonna move the subject matter experts for that particular disaster, trauma, orthopods, infectious disease, whatever, to that hospital. We don't need to credential them because they're already credentialed, et cetera, et cetera, et cetera, et cetera, and apply a lot of this technology, patient transfer, communication, and so forth.
Next question from Jean.
Thank you very much. Interesting information. As a former RN, it really piqued my interest. So adding on to the first question, what about all all the big cities on the West Coast, Seattle, San Francisco, Los Angeles, and then New York. Does any of those cities have anything in place?
Nothing has been done, and even the Bethesda model is kind of stagnant right now. I don't want to get political, but I will. And it has nothing to do with either side, but in 2000, late 2015, 2016, there were a lot of science deniers in government. And not only was this project put on hold, I had negotiated, had a number of discussions with folks in the White House, Science and Technology, around 2016 about there is no climate change, there is no pandemic, there is no this, there is no that. And you need to take down the websites and the information. And my response was, the information that you see on the websites and what we created is not something we made up. This is information that's provided by subject matter experts, Nobel laureates. They're in peer-reviewed journals. They're tried and tested. If you want this to be taken down, you'll have to get a judge to subpoena it down because this is above my ability, my pay grade. That was the last conversation I had with the folks in the White House. A month later, my division was closed, and 70 full-time contractors were just farmed out to other areas. So I really don't want to get into a political discussion, but that's what happened. My people were in charge of we were in charge of a warehouse of 400 ventilators, masks, and everything else. And within a few days, they all disappeared. Some of my folks took stuff from the warehouse, masks and certain critical things that they can carry. And quietly, we distributed those supplies to hospitals that knew about us having this and gave it to them. So.
Next question from Frank. Since then, what has been done?
As far as I know, nothing. I mean, I think a lot of the folks in power know about this. Randy Duncan, who was your representative, I know he got in trouble, but he was very supportive, got us money. And through him, we were working with some of the hospital systems here because San Diego was our second target city. George Worthington, Admiral Worthington, and Randy Duncan, and local folks. And I had come out here a number of times to talk to people about this. But anyway, I'm sorry. Coast Guard?
Next question from Dr. Nolan.
Hi, Dr. Nolan.
I'm curious that you mentioned 400 ventilators were in one place. The reason I'm asking that is because when 9/11 happened, first thing I thought is there should be a bucket brigade for ventilators, because there were going to be a lot of people exposed to respiratory irritants, whatever. How were you going to get those 400 ventilators, wherever they were, to where they needed to be if it were 3,000 miles away? I thought on that day, we should have had a bucket brigade started. Those 400 ventilators ought to be distributed around the country. No hospital system has any excess.
Exactly. No, that's a great question. And I didn't talk about it, but we had set up some warehouses with critical supplies around the country, or we had plans to. We had one in LA and so on and so forth. And the way we determine transportation, whether it be ventilators or antibiotics or blood, we looked at the post office. The Institute of Medicine did this for us, National Academy of Science. We ended up with FedEx. FedEx agreed to be the transport. They know where every package, every pencil, everything is at a moment's notice. And the local sheriffs and so forth around the country would be activated to provide security for a big truck that was carrying, say, medical supplies. For example, CVS has a truck, a big semi-trailer out, driving through the country, dropping off supplies at different pharmacies. That truck would be identified, stopped, and turned around and redirected to where it would be needed. But no, that's a great question. With ventilators, we had models to have 2 people on a ventilator. We had scuba systems that could act as ventilators. So
I want to share another idea.
Can you ask a question?
You could apply this to people also. Way back 30 years ago, we had a backup radiology person in every hospital in this county. Most of the time they weren't being used. So one lady hired them all, and each of them could go to any hospital, which meant there were 5 people in line to serve immediately.
that,
Do that for nurses and doctors too. I last remember that ER doctors had special credentials. They could show up a lot of places.
again, there's no national credentialing system. All of these folks that work in different areas, as you mentioned, they've all passed the medical boards, they're all licensed, they're all credentialed somewhere at a hospital, but they can't go across the street. So this model would allow blanket cross-credentialing and immediate movement of personnel and equipment without having to go through the hospital board.
Okay, next question. Hey, Steve. Let's get rid of that question. As a shipboard engineer for years in the Coast Guard, I've had to deal a lot with disasters, stuff like that. And in the course of your studies, as you know, you get into emergencies like that. And you have people that were maybe the first responders, like on a ship, they get wiped out in the first bit. And then you have people behind them that have no clue what's going on. The reason I ask the question is because, like with the Bonhomme Richard, when they had that fire that started on that one, you have a lot of people that aren't familiar with ships, how you fight fires on ships, or how you deal with emergencies on ships. And there you had something on a large naval base. In the course of what you looked at in these studies, did you bring any outside industries in or look at other, or you just limited to first responders?
No, great question, Murph. And what we did, and I didn't talk about it, we developed a number of downloadable apps that were decision tree algorithms that first responders who are not subject matter experts could use. For example, we had something called WISER, a wireless information systems for emergency response, which had probably still in existence, had over 1 million downloads. And it was a detailed algorithm related to a responder, the incident commander, or the first responder on their phone or laptop computer. There's an unknown chemical spill, a truck turned over. You can't read the placard to know what was on that truck because it's upside down. You could identify a chemical, benzene, chlorine, gasoline, by say the color, what did it float on water, were people getting sick around it? It was an algorithm. You go through the steps and you can identify a class of chemicals, say hydrocarbon. Do you need to put on a protective suit? Yes. What do you do with people who are infected or exposed to it? How do you treat it? You use your digital pen to tell the receiving emergency room what's going on. We did not do anything like that for ship fires or on board, but that's a good thought. I think every subculture needs, we did this with radiation, we did this with trauma, we didn't do it with ocean-going types of accidents.
Basically, I just use that as an example.
No, that's a great example. Yeah, these apps that I told you about not only were specific to the incident, it told you which way the wind was blowing. It had a geographical map. Is there a school in the area? Is there a nursing home in the area? Is the wind blowing? Do we have to evacuate those? I mean, these were fairly detailed, and I didn't go into it because you need hours of time to describe each one.
I knew you were doing more macro than micro, but I was thinking in the long term, maybe downrange more. Micro.
Exactly.
Okay, next question.
If there, if the political situation shifts, are we ready to re-implement all of these plans? Can this be reactivated?
I hope so. I think there are people who are at the second level, permanent folks in government that realize the need for this, because you turn on the news and you want to turn it off immediately. I'm not ready to go back to work. I mean, my only disaster right now is my golf game. But there are people, every Friday, we have a happy hour, quote unquote, conference call with some of my old staff who are still working and keeping up with this. It can be reactivated. I think there has to be a recognition of the need, and there has to be an agreement among the hospital systems that at some level they will work together. And I think they will at some level. But it has to be quick, and they have to do it, be prepared.
Next question, Tom Mercer.
Dr. Phillips, as recently as far as what I know, in the last 6 or 7 years, even the Navy doctors, nurses, PAs, that trained here, had their residency here in San Diego, were only credentialed maybe where they got their medical degree, and here in California. Is there at least nationwide credentialing of any sort going on for military medical personnel?
We tried many times through our medical societies to create a national credentialing system. The states are against it because they get revenue. My license costs $600, $700, $800 a year. I forget. And especially if I want to be licensed in multiple states, you just add that up. If you don't practice there, or you had practice, you don't need to keep it up. Once you give up your license, it's very hard to get back. But we tried to get that in addition to the state licensing. And the AMA and a lot of the medical boards said, well, why would a family doc or an emergency room doc care about national credentialing if they're working? So it's a matter of understanding the depth and the need for something like that. As I said earlier, unfortunately, we have a decentralized system. Everything else is centralized. I mean, military and so forth. And I think this is the way it should be managed at some level. It doesn't have to be managed that way at a daily level, but it should be prepared at a central level.
Next question, RG.
Doctor, thank you very much. It's a fascinating discussion. As a young captain, in the Air Force, I was a disaster preparedness officer in our wing. But I think you have hit upon a problem that is even larger than what you anticipated. The greatest strength of the United States is in our capitalist economy. The greatest weakness of our country is we're in a capitalist economy, which is so decentralized that it resists naturally these types of efforts, which are global, national. And I applaud your effort too. I mean, we're describing the current situation. It seems to me that the people, you described a top-down system, and that is stalled for some reasons. It seems to me there's another bottoms-up level, not at the very bottom, but at the level of the presidents of large organizations and medical. And by the way, I'd also point out this problem also exists in the energy field.
Of course.
We do not have a centralized energy system in the United States, which is one of the greatest vulnerabilities in addition to
and our grid.
Healthcare.
Our
So
grid.
what can be done to engage regional governments and local presidents?
Yeah, no, I agree. And I think we started the grassroots because everything happens there. Coronado Sharp Hospital, for example, I mean, this is just occurring to me. If it somehow put together a program and announced that we're the only hospital on the island, if we have a disaster, we would like to invite non-credentialed Sharp Hospital people who are experts in that particular field, whether it's be COVID or a major trauma or a nuclear bomb that goes off. We would welcome you and we would make it possible for you to come and practice here. Technician, nurses, laboratory people, the whole spectrum from bottom up of what you need. And it could be something that can grow. Now, the complex out in La Jolla between Sharp, UCSD, and Scripps, those folks can get together and easily say, we are going to do this. And how, the big question is, how are they going to get paid when this happens? Medicare was online with being able to track and do these patients. It's the private insurance companies that would have to come online. But it can be done. And I think if it starts at the grassroots, if the mayor, whoever becomes mayor, would take that up on the agenda for Coronado, put together a group to work on it, and Coronado Sharp Hospital can be the example.
Next
Before
question.
one, I just had an idea. And we have all become recently aware that the healthcare system is dominated by the insurance companies. What about an approach to the insurance companies? What the insurance companies do not want, they do not want to be sued over their lack of service. And it seems to me you could have seminars and presentations to insurance companies to convince them it's in their interest to help solve this problem.
No, I agree. There are lots of moving parts and you have to take the decision makers and put them in a boardroom, present the issue and the problem and tell us from your point of view, insurance reimbursement, healthcare response, how are we going to solve it? And you have a moderator, someone that knows about it and say, these are the issues that we have to solve. Communication, patient transfer, information transfer, response, reimbursement, beds and so forth. And I mean, that's what was done in Bethesda. Just put together all the different decision makers from the different groups. And it was very easy. Everybody had their own component. But everything right now is so siloed. And you just have to get them together.
Okay, our last question will be from John.
Dr. Steve, thank you very much for pinch hitting for the mayor. Pinch hitting is always difficult, as you know, in baseball. My question is more generic, and I've learned a lot about disasters, but the question I want your opinion on is the state of doctors, as I see them in the hospital. Caucasian or white doctors are very rare these days. There's a lot more women doctors, and a lot of doctors in the hospitals I visit are from other countries. So could you say a few words from your 60 years of experience in hospitals?
Well, I think we're much better off now. When I was in medical school, my class was about 250, and there were 3 women in the class. There were very few minorities, and presently about 50% of the students in medical schools are women, which is very important. And we applaud that. There are also many more minorities, and there are international physicians. Now, the quality of healthcare, in my opinion, is terrific across the board. It doesn't matter whether you're black, white, green, have horns or whatever, a tail or whatever. When you see a foreign physician in the hospital, they have gone through medical school somewhere. and a lot of, number of Americans go to medical school elsewhere. They have to take a qualifying exam in order to practice medicine. It's the same exam that I had to take, or same type of exam, if you're a foreign medical graduate. And not only do you have to pass a basic exam, if you want to specialize, you have to pass the same orthopedic or surgical or internal medical exam that an American graduate does. So I don't know if that helps. But I knew John was going to ask me this question, and I stayed up half the night trying to come up with it.
Thank you, Dr. Phillips. Outstanding presentation. Thank you very much.
Thank you all for coming. As a reminder, October 25th, we have Dr. Nguyen talking about graceful aging. So please, if you're inclined, come back on October 25th for another presentation at the Coronado Roundtable. And thank you all for coming today. Thank you, Dr. Phillips. And this program will be on the library's YouTube channel subsequent to today's meeting.